Because the whole thing, I mean, we know all the S words together, right? It all sort of blends into this one big mass. But essentially just takes it one step by step, color codes it. I know there's a lot of colors, you guys can get rid of the colors.
There's color.
I made this and pretty quickly, so, but overarching process, spermatogenesis, and then you take it down, and what do we start with, what do we end with, and then spermiogenesis versus spermiation versus spermatogenesis, all rolled up into one. So I'll send it out. If you want it, you can use it. If you don't, you can throw it away. All right, but I'll send it to you after class. All right. And also, I'm going to go back and make one point real fast, and then we'll get started with what we're supposed to do today. If you were taking a picture of it, did you get your picture? I will send it to you, I promise. Okay. This slide right here, just to make sure that everybody's completely clear what I'm talking about with what's going on this slide. You know, we're talking, what are the sustentacular cells, the Sertoli cells? What do these guys do? They're nerve cells, right? So everything, they're kind of like providing sustenance to those little spermatogonia down to the spermatids into the sperm that are maturing, okay? But just so you're aware of what we're looking at here, this line, this circle, is looking, I mean, down the barrel of a seminiferous tubule, right? So the green line represents the basement membrane of the seminiferous tubules. So the Sertoli cells are in the tubules, whereas the Leydig cells, who make what? Testosterone, are floating around in the interstitium between, okay? So does that make sense to everybody? Okay. Any questions about the stuff we did yesterday? I know it's probably not something that you've looked at or thought about yet, but I was just curious. All right.
What would give you that impression?
I just, you know, just reading the room, I guess, you know what I mean? So, let's see. All right, so today we'll finish up the male anatomy. We'll start with female anatomy, and then tomorrow morning we'll finish female anatomy. We'll end at the deeper dive of the reproductive system and the reproductive cycle. And then after that, we'll have a lab and we'll be done. You'll be done with me. All right? So talking about the fluid that is in semen, that is in ejaculate, right? The actual seminiferous tubule fluid, that fluid that surrounds the sperm cells, the spermatogonia, it's a very minor portion of what actually is in that fluid, right? The majority comes from those seminal vesicles. You guys remember where those were? Sort of posterior to the bladder, right? The vas deferens comes up and around the bladder, dips under the ureters, and then hooks into the ambula. The vas deferens become the ambula, and then that leads into the ejaculatory duct, where the seminal vesicles inject their fluid as well, right? Okay. Prostatic secretion a little bit, and bulbourethral gland. The other name for the bulbourethral gland is the Cowper's gland. So all of this fluid, the majority of the fluid that's in seminal fluid or seminal plasma, you might see it called seminal plasma, seminal plasma is everything that is not a sperm cell. Most of it is just nutritious fluid, enzymes, lysozymes, things that help, again, make the journey. We're always talking about making the journey. It's got to get there, all right? So if we're looking at this again, this is the ureters coming down from the kidneys and the vas, hooking over, widens out to become the ampulla, and then the seminal vesicles here into this is the ejaculatory duct, this tiny little piece that's right before the prostatic urethra, right? So it's not technically a part of the urethra, it's a duct. That's why they call it the ejaculatory duct, okay? Then we're in the prostate, the prostatic urethra here. It has little pores where the prostatic fluid comes in. Prostatic fluid, we'll talk about what's included in that. And then the bulbourethral glands or the Cowper's glands are a little bit inferior to the prostate, sort of right along the urogenital diaphragm, and they actually have their ducts that go directly into the spongy urethra. So we'll see those here in just a minute. But seminal vesicles, pouch-like structures right behind the bladder, all right, and alkaline. So why would we want semen, seminal fluid, seminal plasma to be alkaline in general, you think?
Because urine is this.
Because the remainder of the urine in the urethra, right? The urethra is a dual function tube. Most of the time it's passing urine. Urine is noxious and usually slightly acidic or kind of very acidic depending on the patient. So alkaline fluid surrounding the sperm cells helps protect them and neutralize that sort of acidic, noxious environment, okay? It's viscous, seminal fluid, viscous, seminal plasma is viscous in order to help sustain semen until after deposition in the female reproductive tract, okay? Seminal fluid, fructose, again, we just need, it's a lot of sugar, mostly sugar. This is why this is the largest majority of the production of fluid in semen, is so that we have nutrients for that mitochondria to use for those little cells to swim, all right? Prostaglandins, you guys, we've talked about prostaglandins before. These help sort of stimulate smooth muscle contractions. It actually is an irritant to the smooth muscle of the female reproductive tract to help sort of move sperm along once it is there, okay? And then clotting proteins in order to help sort of keep the semen coagulated. And that coagulation initially is to protect the sperm cells, all right? I'm talking about the fluid surrounding the sperm cells. It coagulates, thickens in order to protect the sperm cells, and then there is something that happens with PSA actually that thins it out and allows the sperm to spin more freely once it is in the female reproductive tract, okay? Prostate gland, walnut shape, about the size of a golf ball, depending on how old you are. We're going to talk about benign prostatic hyperplasia. It goes from, golf ball to, tennis ball in a lot of people, honestly. Causes a lot of problems in older men because prostatic enlargement is a pretty ubiquitous and universal thing that happens as men age. It starts to encroach on the urethra, and then you get sort of obstructive urinary symptoms. All right, so it grows, and it says it grows slowly inside from birth to puberty, and then it starts to continue to grow. It grows more and more. At the end of this, we have like a BPH graph, and it is basically from 2 to 100% of people are going to experience prostatic growth. That doesn't necessarily mean everybody in here who has a prostate is going to experience urinary tract symptoms, but everybody's prostate is going to continue to grow, okay? And prostatic fluid, we're going to talk about that. It is a little bit acidic, but it is surrounded by a more alkaline fluid, so it balances out. It doesn't contribute to an overall pH decrease of seminal plasma. All right, citric acid helps us make ATP. And then these proteolytic enzymes, I want to talk about these. What, besides the clotting factors, what do you think? You guys have heard of PSA. Did you know that PSA has an actual physiologic function? It's not just a marker of prostatic growth and potentially prostatic cancer. PSA actually helps break down the fluid, helps decoagulate it. Yes, sir. What is PSA? Prostate-specific antigen. PSA, sorry. PSA. Yeah, good. See, said that in the first day. If I use an acronym you don't know, ask me. Thank you. So PSA, prostate-specific antigen. Typically, if you've heard of it before now and you haven't had any medical training, you've probably heard of it in reference to prostate cancer screening, and it is very useful for that. More higher PSA levels, especially at older age, indicate a prostatic growth, whether it's benign or malignant. But in this case, as far as being a component of seminal plasma, it actually helps thin that coagulation that has occurred after the semen has been deposited in the female reproductive tract for an amount of time. All right, pepsinogen. Does anyone remember what pepsinogen does? Huh? It's a precursor to zymogen for pepsin. Why would it be in seminal fluid? Yeah, what everybody's mumbling right now, exactly. to break down proteins, another proteolytic enzyme, and it's converted to pepsin. It helps break down some of the protein structure and helps fertilization. Helps actually the penetration of the sperm cell into the egg. Lysozymes, in order to keep it safe, if there are bacteria or other things around to help kill that. Amylase helps sort of break down some of the sugars, and then hyaluronase, hyaluronic acid. Have you ever heard of hyaluronic acid? Right? So surrounding the egg is a layer of hyaluronic acid that helps break that membrane down, penetrate it into the oocyte so that the sperm cell can actually fertilize the egg. Okay? And then zinc, antibacterial properties as well. So prosthetic fluid is typically rich in zinc. And so again, that just helps with any of the bugs that are left over in the urethral tissue and maybe in the vaginal cavity until that semen can make its way up the fallopian tube and hopefully fertilize an egg, okay? Bulbourethral or Cowper's glands, there are two of them, tiny little glands, pea size, whatever, that's about approximate. The ducts open directly into the membranous urethra, the spongy urethra, excuse me. The actual glands are located right by the membranous urethra. So remember, we have prostatic, then we have a very short section called membranous, and then we have the spongy urethra. So the actual glands are located by the membranous urethra, by the urogenital diaphragm, but the ducts actually enter into the spongy urethra, okay? So a more alkaline fluid, okay? So I'm going to use a street term, you guys, and the reason why I'm going to say this is because this is how your patients are going to describe stuff. Has anybody ever heard the term pre-cum before? This is what it is. And so I'm telling you that not to be funny or to be a jackass, but for you to understand what your patients are going to say to you in the exam room. And so you can tell them exactly what that is, because if I don't, you might not put two and two together. All right, does that make sense to everybody? Okay. So that's exactly what that is. It doesn't have typically very many sperm. It is a possibility for a patient to make a woman pregnant, to fertilize an egg with just that amount of fluid, because there is some sperm cell in it. All right, so it is a possibility. Okay, why do I even tell you any of that? So that you can give your patients appropriate procreation or contraceptive advice when you're out there seeing them. You will be surprised at the things you have to tell patients in a room with oxygen in it. So just prepare yourself, all right? So if you know these things, I mean, knowing this stuff, knowing some of the things that your patients are going to come in and say, and I've heard a lot of it, and you've got to be able to like game face it and then move on to like, okay, what you're talking about is Cowper's gland secretions. Let's take it down a notch, pal. All right? But anyway, all right? Make sense? So this is a picture you have. This right here is the Cowper's gland. So this is the urogenital diaphragm, okay? And then I just colored right over it, so let me get rid of that. This is the actual Cowper's gland. And you see how it's located by the membranous urethra, this tiny little section right here, but the duct actually comes in to the spongy urethra, okay? This is a little bit better picture. This is the Cowper's gland right here, and this is the duct going right into there, okay? You got your prostate right here. You got your ejaculatory duct right here, and your seminal vesicles. So if you like this picture better, I can send it along with the other thing, but it, just a sagittal section that really kind of highlights everything, including you can see here, coming up the spermatic cord, you've got, what's this? I know it says it on there, but what is it? See what I mean? Epididymis, down to the tail, and then up, vas deferens, hooks around, over the ureter, and back down, and into the ampulla, into the ejaculatory duct, all right? So that's sort of the pathway, okay? Or at least the pathway we've built up to now. Make sense? Any questions there? Accessory glands, pretty easy. Supportive structures, again, prostate has other functions, but in this case we're talking about what does it do as far as the reproductive tract is concerned, and that's what it does. Bulbourethral glands pretty much just have this function, same thing with the seminal vesicles, okay? Semen itself, again, is what we've been talking about, all the components, the cells, the fluid, that's what it is. You might see, like I said, seminal plasma. But if you're talking about seminal fluid or seminal plasma, you're basically talking about the liquid component, not the solid component. In this case, what is the solid component? It's the sperm cells, right? Okay? You will discuss, 50 to 150 million sperm. It's a wide variety. Infertility, as far as a male patient is concerned, is not that easy because each lab, if you go from an institution, labs, values of what's going to constitute infertility is going to change. So I will tell you, prefacing your senior semester, cornerstone of an infertility workup is obviously a semen analysis, you gotta see if they have how many swimmers, if they're swimming in the same direction, what they look like, their motility, right? And that's things that they measure. They measure, are they swimming in the same direction? Because that is what's supposed to be happening. They're all supposed to be uniformly swimming in the same direction, not bumping around into each other. There's supposed to be enough of them. There's supposed to be enough fluid volume, enough fructose in that fluid. So a lot of parameters that come into account when you're checking for male infertility. This is an average threshold. Most centers you're going to see if you have a sperm count below 20 million, that is going to be technically, it's not going to be considered infertile. That's actually a misnomer. This is, to be honest with you, you're not going to be considered infertile. You're going to be considered to have a low sperm count. Infertility is multifactorial, right? What's up?
So, for the vas deferens, if someone's had a vasectomy, is that number 0 or is it just a low?
Okay, so that number is supposed to be 0 after somebody gets a vasectomy, right? There's multiple different ways to do it, right? You can actually excise a portion of the vas deferens. You can take the vas deferens and you can cauterize both ends of it. You can take the ends and you can actually point them away from each other, and eventually it'll scar down and should close. But they are persistent little buggers, so sometimes they will swim across the channel if it's not properly cauterized or closed or taken away. So you have to get a post-vasectomy semen analysis, and yes, what you're looking for is 0. At that point, it's just seminal plasma in the ejaculate. That's all there is, that's all there should be. So it's very important that you tell your patients, again, you're talking about contraceptive management. If they want a vasectomy, nothing is 100% except a hysterectomy, okay? That's pretty much it. So if you have a vasectomy, make sure they don't just assume everything's all good, and then they go about their business and don't come back for their follow-up test, all right? And you usually do that several months later to give it a chance to scar down and heal, so you don't get like a false positive reading. Because if you come back too soon, there may well be some left distal to the incision that would show up, and then you might consider a false positive, if that makes sense. That's a long way to answer your question. Does that make sense? Is that what I'm saying? Good. All right. And we already talked about, again, semen is neutral. Urine is typically a lot more acidic than that, so we want it to be more alkaline to make sure that it's all about protecting the cells to get them to be able to functionally fertilize the egg, all right? And so that's what we're trying to do here. Let's see. This is what happens. This is really what PSA does in this milieu, right? It's not just a marker or a blood test for cancer. It has a physiologic function, and that is to thin back out the seminal fluid so that the sperm, the solid component, can be more motile and actually make its way and swim through it, okay, and make it to the end, all right? So, again, this is one of the I circled it just to highlight it. It's not super important for you guys to know, but what it is this is one of the many factors that they check on a semen analysis to check for liquefaction, to see if it doesn't liquefy. First of all, it doesn't coagulate appropriately, then it's a much higher likelihood that sperm will not make it. If it coagulates too late, again, same thing, it just reduces the chance that sperm cell is going to make it to the oocyte. All right. And then this is something that is fairly disconcerting to your patients. Oftentimes it's just an inflammatory response. It's often not a traumatic thing. It may be an infectious issue. It may just be an inflammation. But needless to say, when there's blood in the patient's ejaculate, it catches their attention. And so typically reassure your patient that it should resolve on its own. It would do you good, do you well to give them an STI panel to check. We're not going to talk about what you need to do to work it up. But the reason I bring it up here is because when you think about it, it sounds really bad. Oftentimes it's really benign. Okay, so anyway, any questions up to now? Okay. So the root of the penis here is attached deep to the body, right? There's by two crews. What is it? Have you guys talked about a cruise of anything else before? I don't know if we mentioned the cruise of the diaphragm, but essentially what it is a bony attachment, like a muscular bony attachment of an organ or a of anything really. So if you look, I'm gonna go to the picture first. I'm gonna go back to the diagram. But this down here is the perineum, right? So what we're looking at here is the bulb of the penis. It's sort of this root piece right here. It's attached to the ischiocavernosus muscle, right? So ischium, right? What's the ischium? It's that bone. The cavernous bodies are those two paired structures right here. So ischiocavernosus is this muscle here. And then the bulbocavernosus is this muscle right here. Or excuse me, did I say that backwards? Bulbospongiosus is this muscle right here because it's attached to. Stop. Stop, Chris. Just reset. Control Alt Delete. You gotta do that again every once in a while. See? Gets to the best of us. So, not that I'm the best of us, but I'm the only one standing up here. So, bulbospongiosis. This is the spongy corpus spongiosum, the single one, okay? These are the corpora cavernosa, all right? So this is the ischiocavernosus muscle. So both of these muscles, why are they important when they contract? What do you think part of their contraction does? Huh? Part of it is trapping of blood. What else do you think a muscle right there at the base of the penis would be, especially where it, huh? Yes, propulsion of the ejaculate, propulsion of the seminal plasma and the fluid. Yep. Okay. So let me go back. That's the root of the penis. The crus of the penis are these sort of sections right here where they are attached in here to the bone. So these sort of flayed areas right here that's beneath that muscle, but this sort of is the crus of the penis. All right. So the deep tendinous, if you will, attachment. Okay. Now let me go back. So the crura are there together. That's the plural of crus. So if you see that word, you're not sure what it is. It's plural. And two ligaments, the fundiform ligament and the suspensory ligament, help sort of, again, continue that that ligamentous attachment to the penis and give it also stability and help with erectile function as well, right? So you guys know what the linea alba is?
Yes.
Huh? Are you sure? Are you okay? I didn't realize the linea alba was hilarious. What's going on? All right. All right, and then the suspensory ligament from the pubic symphysis. All right, so if you go to the linea alba, that is the fascial tissue right here on the rectus abdominis. Okay, and so you have the suspensory ligament right here, literally suspending the penis and helping with erectile function, and the fundiform ligament that's right here, helping also. So even though one's called the suspensory ligament and the other one's called something else, they both essentially have a similar function. Okay, so the fundiform ligament is that dark blue thing, that dark blue sort of like wishbone looking thing, right here. And the suspensory ligament is actually this one that looks more like a ligament coming from the symphysis pubis. Okay. All right, so the body of the penis it's mostly erectile tissue. The spongiosum is erectile tissue as well. The cavernosa is the main erectile tissue. You know, what does corpora cavernosa mean? It means cavernous body, and that's exactly what it is. It is just a big space that allows to be engorged with blood. It's surrounded by something called the tunica albuginea, which is a rigid, fibrous tissue that helps maintain that blood within the cavity, and then you have a maintenance of a rigid, firm erection. Okay, so spongy osum, right? Spongy urethra, right? The corpus spongiosum contains the spongy urethra, so there are two paired cavernous bodies, dorsolateral, and one inferior underneath, the surface of the penis, surrounding the urethra is the corpus spongiosum. The spongiosum is also continuous with the glans penis. So there is erectile tissue in the head of the penis as well. Okay? And if you look at this, so, well, take it easy, pal. If you look at this, the cavernous bodies are here, and you can see them. This is like a picture of flaccid and erect. Basically, all of this tissue here just engorges with blood. This tunica albuginea, which is this white membrane, it's also the one that surrounds the testicles. It's not contiguous with this membrane, but it's the same tissue. All right, it surrounds both the spongiosum and the cavernosum. Okay, and then once you have erectile function here, you see sort of these veins become compressed. So you have some also additional outflow prevention. So when you have an erection, the patient has the fluid blood filling the cavernous bodies, and then they have sort of an obstruction to venous outflow, and that helps maintain erection rigidity. We'll talk about that here in just a second. But as you're looking at this, the spongiosum here comes surrounding the urethra, and then it also is within the glans penis. So there is erectile tissue there. And these on either side, this right here and this right here, are the cavernosum. So don't get it confused by the way it looks. There is only one spongiosum. It's surrounding the urethra, and then there are two channels, if you will, that are the corpus cavernosum. Okay. Fractured penis is a real thing. You guys want to know what this is called? It's called aubergine sign. Does anybody speak French? It means eggplant. All right. It is usually an injury that occurs during sexual intercourse. What happens is you have engorgement of that blood in an erect penis. That tunica albuginea is covering. What happens is typically there is an injury, an insult, and you get a disruption of that tunica albuginea. So ultimately what happens is, if I want to go back to this, what happens is you get like a disruption here, and then you get blood, you get bleeding coming out, right? So all of that blood that's being held in the penis is pulling out, then you get a curvature, right? So what needs to happen typically is that what that needs to happen is a surgical correction to repair that tunica albuginea. Otherwise, you have a significant risk of loss of sexual function, potentially loss of erectile function. And then what's more likely to happen to this patient later on in his life is Peyronie's disease. Have you guys ever heard of Peyronie's disease? So Peyronie's disease is basically an abnormal curvature in the penis. What's going to happen at that site, especially if it's not fixed, if the patient's lucky, is he's going to develop basically a scar tissue, like a big scar tissue right here, the tunica albuginea. And then what's going to happen, as it engorges with blood, there's going to be essentially a pivot point. Whether it pivots laterally or up or down, that's immaterial. Sometimes Peyronie's disease can be so dramatic that the patient literally cannot have sex because the bend is so dramatic. And oftentimes, at least in the initial stage of the development of Peyronie's disease, it's very painful. Okay? You want to hear something that's sort of humorous, and I think they do it so that you'll remember it. There's a medication for Peyronie's disease in order to help loosen and sort of eliminate the scar tissue that usually develops, because it can also be non-traumatic. You can find that medication at bentcarrot.com. Right? So, and I'm not kidding. Right. The glans penis, and I do appreciate the little Google Maps thing down here. But the glans penis is the head of the penis, all right? The entire thing is the head of the penis. Let me get rid of that stupid thing. The entirety of the structure is called the glans. This ridge right here that goes around sort of the base of the head, if you will, sort of the proximal portion of the head, is called the corona, all right? So corona meaning crown, and sort of, it's a raised ridge structure. All right, it like I said, it does contain corpus spongiosum, so there's erectile tissue in that portion as well. Right. You have the little glands here, which is what the Google Maps thing is pointing to, the prepubertal glands. They are actually what secretes sort of a thick, waxy-like substance called smegma. Right? Smegma has a physiologic function, literally, of lubrication of the tissue and sort, but it also, in a patient that is uncircumcised and maybe has some poor personal hygiene or not necessarily the best personal hygiene, it can also serve as a breeding ground for bacteria and fungi, right? So you guys know, like, where do fungi, yeast like to grow? Do you guys know? Warm, dark, moist places. And that's exactly what it is under the foreskin if your patient doesn't have good, meticulous personal hygiene. And so that may it may sound funny, tongue-in-cheek, but ultimately what can happen is some pretty serious injuries to that patient, depending. And I'm not going to go too far into it. Ultimately, what can happen is that patient might ultimately need to get a elective circumcision as an adult. I've had to send patients for elective circumcisions as adults just because they continue to get yeast infections. And then what that can lead to is a swelling of the glans penis, a swelling of that tissue, and then that patient can be at risk for something which we'll talk about in a minute called paraphimosis or phimosis, okay? So anyway. And this is, again, depending, circumcision is typically more of a social religious practice than it is any kind of medical necessity, right? There are times when it does become medical necessity. If a patient experiences phimosis or paraphimosis, then usually we will do an elective circumcision. I'll explain that in just 1 minute. But in the vast majority of cases, it's just a personal decision of the parents of the patient, typically because it's usually done in infancy, all right? It doesn't necessarily reduce, it can lead to a slightly increased risk of UTI just because there are potentially more bacteria near the urethral meatus. But again, while we talked about men usually don't get urinary tract infections, it's just because the physical length of the urethra that has to crawl. So it does give a theoretic increased risk, but not really. I haven't seen that, manifest, in my clinic at least. So this is the problem. It's not just the smegma that builds up. Again, it's also a source of potentially yeast infection, candidal infection. Have you guys heard of Candida albicans at this point, right? Your typical yeast infection. Yep. And so again, you have to really educate your patients to, if they're having that problem, that they need to withdraw the foreskin, clean under there, and not just clean under the foreskin, but also dry it, especially after showers and so on and so forth. Or else again, it just builds up, the moisture just builds up, and so then the possibility to seed another infection happens, okay? So this is phimosis versus paraphimosis, okay? Phimosis is a condition where the foreskin is drawn over the head of the penis, the glans penis, basically in its resting position, if you want to call it that. But it cannot be withdrawn back. Like, it can't be pulled back over the glans penis. That's less of an emergency. That's not an emergency at all, frankly. What that does increase the patient's risk for is these yeast infections and ultimately squamous cell carcinoma of the penis, which, gentlemen, thankfully is rare, very rare, okay? Paraphimosis, on the other hand, is an emergency because what that is foreskin that has been withdrawn over the glans penis and now cannot be reduced back into its normal position. And what does that sound like? A tourniquet, right? A tourniquet, because it's usually due to some sort of inflammation, okay? That's one of the things that can happen if you have chronic yeast infections, chronic infections under the foreskin. If that inflammation can cause an inability to return the foreskin back to its normal position, and then that could lead to potential loss of tissue, because there is, and this possibility, a real possibility of ischemia, and ischemia leads to necrosis, right? So this would be a good reason for an elective circumcision. This one is a reason for a non-elective circumcision, because if it happens once, it can happen again, and the second time it happens, that patient might not be as lucky. Just like with testicular torsion, so they basically remove the foreskin in order to eliminate entirely the risk of it happening, okay? Erectile physiology, any questions about that stuff? Okay. Erectile physiology, typically a parasympathetic reflex to attain and maintain an erection, right? Feed or breed versus, right? Versus fight or flight, right? You guys, okay? So, nitric oxide helps smooth arterial wall relaxation. Again, I think I have told you this in the past, you will have patients who are taking over-the-counter nitric oxide supplementation that's marketed as erectile dysfunction medication. It's not gonna work, okay? So, but nitric oxide does have a physiologic role in the relaxation of the arteriole, so that allowing the dilation, allowing that blood to come in, right? Right, basically to fill the cavernous bodies, right? You fill that erectile tissue, right? And then, like I said here, as the erection is achieved, you get compression of the outflow. Compression of venous outflow helps just trap that blood in there until it's time for the erection to go away, okay? Oh, what's that? The black on that. So, sympathetic reflex is ejaculation. So it sounds counterintuitive. There is parasympathetic and there's actually somatic involvement in the actual process of ejaculation. But the sympathetic stimulation is basically what helps, this is as you, I think whoever was said, helps the peristaltic contractions to actually bring the semen and the sperm, the seminal plasma into the urethra and then propel it out, okay? And so you get pudendal nerve stimulation. That's a lot of interplay between parasympathetic, somatic, and sympathetic nervous system that is involved in the actual final process of ejaculation. But again, contraction of those muscles propels the ejaculate forward and out, okay? And that is the process. And after that, you have, so, tumescence. Anybody familiar with the term tumescence? Tumescence is achieving an erection, achieving rigidity of the penis. Detumescence is returning to the flaccid state, returning back to the flaccid state. So if you ever see those words, that's what they mean. Did you have a question?
If someone has a spinal injury that impacts the lumbar portion,
Uh-huh. They typically, ejaculation can be inhibited. Yeah, they will usually, they will usually be able to produce some sort of ejaculate. But what the problem there becomes then is erectile function itself. And so if you have lumbar, sometimes even sacral injury, then you have to think about erectile function. Obviously, if you go up higher, same thing, because you lose function distally. But there are plenty of surgeries that they have. There actually is, in those cavernous bodies, what they can do is essentially insert two balloon-like structures. And then there is a air reservoir that is placed in the patient's scrotum. And literally, the patient can pump it up, and then when they're finished, there's a button to hit release. It releases the air from the balloons in the cavernous bodies back into the reservoir, so they can have erectile function, right? And I used to tell, with the seniors, like the jokes write themselves when you talk about ED and stuff like that. It's easy to joke about, but imagine not being able to have sex with your partner ever again, and think about the quality of life issue that brings along with it. So these surgeries, these medications, I mean, they are life-altering for these patients, especially somebody who's in a wheelchair, or some paraplegic, quadriplegic, somebody who can now have sex somehow with their partner, with their intimate partner, whoever that may be. That is quality of life. Should not ever be discounted in patient care. Does that make sense to y'all? You know what I mean? So that was a long-winded answer to your question, but I think I got there. So speaking, right? So we're not going to talk about much of the intricate physiology of erectile dysfunction, but needless to say, as the erectile physiology progresses down the biochemistry, if you will, of erection, you get to a compound called phosphodiesterase 5, PDE5. All right, phosphodiesterase 5 sort of breaks the chain and inhibits erectile function. And it's one of the things that's involved in detumescence as well, upticking phosphodiesterase 5. So, everybody knows what this little guy is? The Viagra pill, right? Viagra, Cialis, Levitra, Stendra are all phosphodiesterase 5 inhibitors. Okay, so if you hear the term PDE5 inhibitor, that's what that means. And so it inhibits the production of that cyclooxygenate, the PDE5, and allows erectile function to happen. Okay, it still requires sexual stimulation. These drugs don't just produce an erection. There are drugs that do, something called alprostadone, which you can actually use in clinic sometimes to produce an erection to see if the patient can even physiologically and anatomically achieve an erection. But these actually still need sexual stimulation. Pretty ubiquitous. What's the most popular side effect? You guys think? Priapism, right? Prolonged erection. That's actually the least common, but most popular side effect. Priapism is uncommon with these drugs, unless you combine them with like cocaine or something like that. Then so game off. But so these that's actually very, very safe, right? The biggest actual side effect, the biggest most common actual side effect is hypotension. If this patient, especially if this patient is on another kind of blood pressure, because they do also cause hypotension. They're initially not erectile dysfunction drugs. They were initially blood pressure medications, and then patients came back and said, "Doc, guess what?" And so, bing, money. Now we have erectile dysfunction drugs. Okay. Anyway, if you want to talk about causes, hypertension, diabetes, it's on every list, you guys, right? Drugs, illicit. I know it says illicit on your slides. Spelling is hard. So illicit drugs, marijuana is a big one. Okay, when you talk about that, illnesses, trauma, psychological. This is a big one. We bucket ED typically into two main categories: organic and psychogenic. All right, and most of the time there's a big crossover, right? Organic meaning there's an actual physiologic anatomic cause. Something is happening. Psychogenic means it's more psychological. And if you think about it, if you introduce high sympathetic stimulation, meaning anxiety, whatever, then that first initial portion, which is parasympathetic charge, erection, is not going to happen, okay, for your patient. So counseling is a big part of ED treatment as well. But what's not on this list that is a huge, it's not on this list and it needs to be on there, probably needs to be number one. What do you guys think is the number one ED risk factor? Age? Kinda. And alcohol should be on there too. Keep going, what else? Huh? Cardiovascular disease. Yeah. Cardiovascular disease, particularly hyperlipidemia. Yeah. American Urological Association, just so you guys know, considers an initial visit for erectile dysfunction as an appropriate time to discuss cardiometabolic risk factors with your patient. Because oftentimes you'll find that they are sedentary, they're smokers, they are drinkers, they have a poor diet, they don't exercise very much. So, all the risk factors you have for a heart attack, same risk factors you have for erectile dysfunction, and sometimes that erectile dysfunction will be the first thing that walks in the door, right? Because, not to get in the soapbox, but I'm kind of on one. A patient's going to come in because of their hyperlipidemia. Do you have symptoms from hyperlipidemia? Notwithstanding heart attack and everything like that, let's just say you have mild hyperlipidemia. Do you have any symptoms? Yes. Do you have any symptoms really from hypertension? Hey, don't fucking think I'm trying to do. No, you don't have any symptoms from You don't have any symptoms from You'll generally know, right? Yeah, you might have a headache, you might have blurry vision, you might get ringing in your ears if it's really bad. But if you have mild to moderate hypertension, feel fine, right? Smoking is great. Drinking is wonderful, right? So I don't want to stop doing those things. I don't need to exercise because I ain't never been sick before, right? So why would I go to the doctor? What is going to bring that guy into your office? I can't get it up no more, doc. So that's why they say it's a very good it's a good time to potentially intervene with a patient that you might not have ever seen before and you might not ever see again if you don't break through that membrane as much as you can. Does that make sense to you guys? Yep. All right. Priaprism, okay? Technically, I don't know if anybody in here is old enough to remember the commercials, but if you have an erection lasting more than 4 hours, that is the clinical definition of priaprism, an unwanted erection that has lasted more than 4 hours. That's the actual temporal cutoff. Again, not super common with the ED drugs, but common for other there's a multitude of reasons. Sickle cell anemia can cause priaprism. And literally the sickle cells can't escape. Right? Trauma can cause it, so on and so forth. There's 2 different kinds, and we're not going to go into that too much, but there's ischemic and non-ischemic. Which one sounds worse? Ischemic, right? That's kind of an emergency. That's one that needs to be addressed quickly. Just to give you a little, you can inject phenylephrine into the corpora cavernosa in order to overwhelm the sympathetic side overwhelm the parasympathetic urge with an adrenergic response, and so you can actually induce detumescence with phenylephrine, which is typically used as a cold medicine, right? A decongestant. The one you can't make meth with, so you can buy it over the counter. You don't have to go to the pharmacist to ask for real Sudafed. Anybody? No, nothing. So, all right. I think it's a good break time. Then we'll have a few more slides. Now it's going to get complicated, you guys. All right. So. Ultimately lead to something that's called, it resembles like a Parkinson. Or that's just sort of going to coagulate. So it's not necessarily going to cause necrosis, but what it's going to cause is like just acidity and increase in sort of like so it doesn't really cause necrosis tissue at all, otherwise there is, I mean, so what do you do? Is it primary good health failure like the patients are literally not working, that they respond to, or is it pituitary failure? So you have to kind of discover where that you're not necessarily ever really going to raise the threshold of feedback. Is it possible to lower the threshold of feedback? You remember that. And in order to do that, you have to have a gonadotropin releasing animal. I don't think so. No, I understand. I don't get how there might be. There probably is. I don't know. Honestly. Yeah, yeah. Yeah, no. Yeah, yeah. Of course we get. And the funny thing about it is, man, you're giving a guy back his testosterone for his mind. Ask them, right? Gas station, right? You can cycle off, and then they try to cycle off. What happens? Because you're in this production. So you go from feeling kind of bad, feeling fantastic, to feeling horrible. And then, oh, guess what? I'm gonna go back. First, just a little taste. From what I've heard, from what I've been told, from what I've found. Oh wait, no. Honestly, the biggest thing you can do for yourself is maintain sort of exercise and maintain a lean of a body mass. You're doing this really, and you just touch the deck. You have those guys that say, look what that. A lot of that is progression, that aromatase happening here. Belly fat. Belly fat is a huge risk factor. So hey, check this out. Okay, now bro, even just get last day. No. It's actually meditation. I think it's yours. You're seeing how I feel it though. It's gonna get there. I'm thinking it's this. You got you go for it minimal. Rub it on this. Or honestly, you just like, they may have usually if it's just
It's like when you wondered the night, what are you doing?
okay, so a lot of people have some hours or it's like inflammation. If you have sperm cells into this, you can have what's called retrograde shit. Yeah. Into like coming out. So there's some kind of diabetes. First you got All right, shall we? We shall. Okay. All right, so we're gonna go through follicle development today. We're gonna stop, and then we're gonna talk more about anatomy tomorrow. And then, like I said, on I think it's Tuesday, we'll go through the reproductive cycle with all the various hormones and events happening in the uterus and the ovaries and so on and so forth. So the gonads, again, the gonads are the gamete-producing organs, all right? So in this case, we're talking about the analogous structure to the testicles, which is the ovaries, all right? They're about the size of almonds, so when you are out there and you are doing well woman exams or bimanual exams and you don't feel ovaries, that's good. Because you shouldn't usually be able to palpate an ovary unless you have an extremely thin-walled patient. Most of the time you can't feel it, just like have you guys tried to palpate kidneys? And you're just like, yeah, you totally feel it. You shouldn't be able to feel kidneys, you shouldn't be able to feel a non-pathologic spleen. This is another one of those things, okay? All right, what you're looking for when you do that bimanual exam, if there's any pain, tenderness, stuff like that, but actually trapping an ovary and feeling is difficult, if not impossible, okay? So, speaking of the ovaries, we have two, right? Either side of the uterus, they're connected with ligamentous attachments to the fallopian tubes, but not physically, right? So these little sort of finger-like productions on the fallopian tubes, which we'll of course talk about, are called fimbriae. So when ovulation actually occurs, it occurs in sort of this space, right? This is peritoneal space, if you will, and the fimbriae sort of wave through motions like that, literally bring the egg, the oocyte, into the fallopian tube, okay? So that is one of the ways that ectopic pregnancy can happen. If the sperm makes it all the way up here, you can actually have a fertilization out here, okay? Because of that lack of electrical connection. Anyway, it's fixed fairly strongly in place with the ligamentous attachments it has, the ovaries and the uterus itself. The ovaries have the broad ligament. I'll show you the ligament. It goes behind the actual uterine structure itself, covers the fallopian tubes and the ovaries. The ovarian ligament actually anchors the ovaries to the uterus itself. So again, it's just a ligamentous attachment. It's not that the ovary doesn't physically attach to the fallopian tubes. And then you have a suspensory ligament to anchor them down to the pelvic wall. Again, all of this just like when we talked about our mesentery and mesocolon, so that things cannot twist around. Because we did talk about our testicular torsion ovarian portion is also a real possibility for a female as well. So that has to be in your differential diagnosis for acute onset lower abdominal pain or pelvic pain in a female patient, okay? The hilus, just like the hilums and the hilus in the lungs, it's just the point where blood vessels, lymphatics, veins all enter the ovary itself, because again, it needs to be fed. It's an organ, it's a structure. So, you have the ovarian ligament, like it says, it is just the ligament, okay? That is not a tube, that is not a pathway, that is not where the egg goes once it's ovulated. That is a ligament. It's just holding the structure in place, okay? Again, as ovulation occurs, it's got to go up through this way, just so you know. Because I've seen students who thought that the egg went through that tube into the uterus. That is not what happens, okay? It's not a tube. The broad ligament is going to be this thing in the background here. We have a better picture of the next one, but it basically is exactly what it sounds like. It's a very broad-based ligament that holds, essentially anchors down the entire ovary, uterus, and fallopian tubes. Alright. And then the suspensory ligaments here, okay, in this part up here. Looking at this one, again, the broad ligament is that whole like wing-like structure that keeps it together. The suspensory ligaments sort of anchoring it here, the uterine ligament anchoring it here, okay? Easy enough, as far as ligamentous attachments. The ovaries themselves, multiple layers. They have a tunica albuginea as well, except it is not the outer layer. There are germinal cells on the outside of it. Tunica albuginea, much like it does with the testicle, gives it support structure and maintains the shape of the overall ovary, just like the same thing with the testicles, okay? And then the ovarian cortex is in the middle, where all of the stuff that happens in follicular development and the reproductive cycle occurs, which we're going to talk about in great depth coming up, okay? The follicles are in the cortex, and the granulosa cells are things that actually surround the eggs. And we'll talk, we're gonna go through follicle development, follicular development here in just a minute. So granulosa cells, sort of stromal tissue that helps support the egg itself, the oocyte, right? And then here's as good a point as any. As we're going through this follicular development, make sure that you separate in your mind the difference between the follicle and the oocyte. Because there's going to be primordial, secondary, tertiary follicles. There's going to be primary and secondary oocytes as well. Just to make it easy, the follicle is the whole thing, and the egg is just the thing in the middle. So the egg is in the middle of the follicle is the whole thing. Okay? Well, that should make more sense in a minute. It's never too early to preface that because I don't want you to get it confused. So, looking at this is a picture of multiple stages. This is not what it looks like. This is basically a time lapse, if you will, photograph of an entire female reproductive cycle from the beginning of development all the way through to ovulation and then beyond. Okay, so not all of these things are occurring simultaneously, so don't think that they are. But it's a good encapsulation to just see it on one drawing, all right? So let's talk about oogenesis. Just like spermatogenesis, the prefix oo relates to ova and relates to ovaries, okay? So, before birth is where oogenesis begins. Remember, if you talk about spermatogenesis, you have something that's called pre-spermatogenesis, but you don't really have the development of mature sperm cells in a male patient until puberty, all right? That's not necessarily the case here. This begins in gestation. So when your patient is still in utero, that's when she will start to develop and will develop the eggs that she will have to utilize for the entirety of her life, right? Female reproduction ends at menopause. Somebody asked me, just so everybody knows, technically a male can be fertile from puberty until the day that he dies. Has the ability to make a motile mature sperm cell, and that cell can penetrate an egg. Now, will it is another story. Depends on comorbidities of the patient. Depends on several other factors. But a female's reproductive timeline ends at menopause. A male's begins at puberty and ends when he's dead. Okay? And in some cases, not even then, because you can harvest sperm from a recently dead person. So, anyway. So, same kind of thing as far as mitosis, meiosis 1, meiosis 2. Alright? But we'll talk about these. You get, see the prefix gonia, like spermatogonium, right? What is that? It's the initial cell, right? It's that initial thing that's attached to the sustentacular cell. Same thing, oogonia is the analogous cell, okay? 2N, right? And then it becomes primary oocyte, just like primary spermatocyte, okay? Difference here is we're still in utero. They basically stop in meiosis 1. So it remains a diploid structure until puberty, just like until menarche, if you will, when the patient begins to ovulate. Menarche, the initial ovulation, okay, the initial period. It's arrested at that site, and it's surrounded by granulosa cells. So that entire thing, and I'm going to show you the picture next, it's nice and clear, I think, when you see the picture. The entire thing is called the primordial follicle. Follicle, the whole thing. Okay? Primordial follicle contains the primary oocytes. Okay? So let me show you. So if you go back, I just want to show you something here. So oogonia, right? 6 to 7 million of them. Now, I'm sure all the females in this room know you don't have 6 to 7 million periods in your life. So many of these, the oogonia, this number comes down exponentially until we get a fixed number of around 400 eggs that a woman is born with, right? Just around. So, a lot of these primordial follicles, again, like that's why I wanted to bring that up. A lot of these will just die by atresia, go away, be reabsorbed. But again, as after the patient is born, that process of being able to create more eggs ceases. Unlike, again, a male patient who continues to produce sperm. So now, here we go. Follicle is the whole thing. This whole thing you're looking at is the follicle. The oocyte is this thing right here, okay, surround. And the granulosa cells, these guys right here in the middle. Not, the outside cells are called stromal cells. What does stroma mean? You guys remember? Supportive tissue, supportive cells. The granulosa cells are inside the basement membrane, immediately around the oocyte. Okay, so it's one layer. That's why it's hard to see on that picture maybe. It's a single layer of granulosa cells surrounding the oocyte. But everybody understand, decouple those together. Follicles, the whole thing, eggs in the middle. Got it? Yes? Okay. So this is sort of what I was talking about. During gestation, you've got 7 million down to about 1 million at birth. Continue to sort of undergo atresia. You guys know what atresia means? You guys heard this before? Sort of slow death, attrition, sort of wasting away, basically cellular death. You don't end up with 1 million or even 300,000. About 400 will ultimately end up being mature and be ovulated, which equals about 400 menstrual cycles. Now, of course, that can change from patient to patient, but that is an average number, okay? So, and again, if this seems, the reason I've said it 2 times now is because if this seems superficial as far as the egg development and what happens, we're going to cover it again during the last course when we talk about the reproductive cycle and what, we're going to do a deeper dive into this stuff. So if you're like, wasn't there a lot that goes on? Yes. But right now, we're just literally going to talk about the egg development. Okay, does that make sense to everybody? All right. So, you see what FSH and LH? So every month starts typically, under normal conditions, one mature egg is going to be ovulated from one ovary, okay? Otherwise, what happens? Twins and all kinds of weird stuff, right? So, all right. We're at the primordial follicle, that first picture we saw. One layer of granulosa cells, some stromal cells on the outside, the oocyte in the middle, right? Now, here we go. Follicular development. Primordial follicles become primary follicles. We have the granulosa cell that becomes from one layer deep to multiple layers. That becomes important because those granulosa cells start to secrete estrogen-containing compounds. Right? That starts to help the maturity of the whole follicle along. Right? The theca folliculi surrounds the basal membrane, and this right here, the zona pellucida. Remember how I've been talking about what the sperm ultimately has to penetrate in order to get into the egg and deliver its genetic material? That's what it is. The zona pellucida is what all of those enzymes, all of that mitochondria to whip that tail through, that's what it has, the final step. That's when that acrosomal reaction happens. Remember that? The capacitation, the acrosomal reaction, releasing all that stuff so it can break through the zona pellucida and then deliver genetic material, fertilize the egg. Okay? Okay, you guys? All right. So, on the picture, the granulosa cells are this layer right here. Again, so it goes from one layer deep to multiple. The zona pellucida is this immediate shell, if you will. If you want to think of an analogous structure, it's the shell of the egg. All right? So that's what the sperm cell has to break through in order to get to this little guy and combine their stuff. Okay? Ultimately. Right? Make sense so far? Sort of? Yeah?
What is a primordial follicle? Is a stromal cell layer also called theca follicula, or
No, it's just like, yeah. So then it differentiates even more. No, let me go back. It's just the granulosa cells and the stromal cells, right? We have, when it becomes a theca folliculi, is when it starts to create a different layer, like it thickens out here more or less. That's what that means. So not really. It's just stromal tissue on the outside of the primordial follicle. When it's a primary follicle, then it has that named layer, theca folliculi. Does that help? Okay. So, now we're going to a secondary follicle, just like secondary spermatocyte. Remember, we're following a very, very similar pathway. That's a good question for the caveats onto this. Now it becomes an internal and an external layer, okay? Right? And you see the theca interna also helps convert some of the precursor into, the androgen precursors into estrogen. Again, estrogen being a very, very important hormone in this entire process. So we have, inside the cell, we have those granulosa cells secreting some estrogen. And then outside, we have the theca interna helping to convert additional estrogen, right? If you look here, the granulosa cells are secreting this fluid. It's got to take up space. That space becomes called a structure called the antrum, right? So I'm going to go two ahead just to show you. Right? So as these cells start to secrete this fluid, that negative space you see is called the antrum. Okay? And as they secrete more and more fluid, it gets bigger and bigger. Okay? Does that make sense to everybody? And go back. Okay? So we got the antrum. In the secondary follicle, we have the innermost cells of the granulosa cells, like the innermost cells of the inside, immediately surrounding the egg in the zona pellucida, right? Right, the zona pellucida is the shell of the egg. Right around that shell is a crown of cells called the corona radiata. Right, what does corona mean? Crown, radiant crown. Okay, so here You have this antrum developing. You have this zona pellucida, like I said, it's the shell of the egg. And the corona radiata is the initial one cell layer of cells around it. Does that make sense? Sort of? Yes, sir.
I just have a question back on the
Okay.
originally they said it was stromal cells, but then when it differentiates,
I'm sorry.
so the granulosa cells are not part of the original.
No, the granulosa cells are inside the inside. Where are we talking about? What number are we talking about?
Slide. Well, yes, so.
That's the primordial follicle, so we don't have a theca folliculi there.
Yeah.
So what are we talking about here?
Between primary and secondary, so it's granulosa cells,
Uh-huh.
not part of the thick folliculi.
No, the granulosa cells are inside the basement membrane. The theca folliculi is outside that basement membrane.
Yes, and then in the secondary follicle, since the folliculi differentiates, they turn out that that's where it says granulosa cells occur.
Oh, it means also that it's not, no, the granulosa cells are not part of the theca folliculi. It's saying the theca folliculi separates into those two structures and the granulosa cells continue to secrete estrogen containing fluid. So the granulosa cells are still on the inside of the basement membrane. The theca interna externa are still on the outside of the basement membrane, but it's just that it's just two thoughts on the same slide, right? So the theca interna, you see how we kind of have this, you see how we have this kind of like whitish ring, right? That's the interna, and then the externa is sort of the outside, way outside part, if that makes sense. Does that answer your question? And then the granulosa cells are all the purple things on in the inside that are surrounding the egg.
Yeah, it should be, that was underneath the.
Oh yeah, it's just, I mean, the slide, I'll have to clear that up, but what he was asking, so granulosa cells are all these purple cells inside the basement membrane, right? This little white, which probably shows up better on your small slide, but that's the interna, and then the externa is out here. So the theca interna and externa are both outside of the basement membrane. The granulosa cells are inside the basement membrane. Okay? Is that clear to everybody? All right. Yeah, I see what you're saying now. It's just I'll have to like put a separation in there to make sure, because it's not part of that same structure. So thank you. There is actually a tertiary, or what's called an antral follicle. It's not on here. We're not going to worry about it. Don't worry about it. But ultimately, before it actually becomes a mature follicle, that antrum basically almost entirely surrounds the oocyte and the corona radiata. And then what is expelled during ovulation is that mature follicle, okay? But we're going to stick with what's on the slide. So I just want you to know there is a structure called the tertiary follicle. Just imagine that white space in the granulosa cells, basically almost going entirely around except for like one little isthmus of granulosa cells, right? Does that make sense, everybody? So there is another structure, but suffice it to say. We'll go to the Graafian follicle, the mature follicle, okay? So, remember, we're still at a secondary follicle and a primary oocyte, right? So again, keep these straight. The secondary follicle still contains a primary oocyte, okay? So it still contains a diploid structure. Now, as we are about to ovulate, okay, the primary oocyte undergoes meiosis, okay, it completes meiosis 1, and it produces 2 haploid structures. One of them becomes the secondary oocyte, it's the bigger actual oocyte, the thing that is ovulated. The other is just a tiny little structure called the polar body, the first polar body, because there will be a second polar body. The first polar body, it basically just is reabsorbed, the unused genetic material, okay? So basically, haploid, diploid becomes haploid, one thing becomes the main egg, the other thing is just the other 23 chromosomes that just reabsorb. Does that make sense, everybody? Okay? And again, this undergoes meiosis too, but it stops at metaphase. And why? When does it pick up again? When the other half of the chromosomes are delivered by the sperm cell, and now it can become a zygote, right? Just so you're clear about why it would arrest in that phase again. Or at this point, I should say. Does that make sense, everybody? I know, again, it's just like spermatogenesis. You're going to have to go through it a couple of times in your mind, but ultimately the process is not super difficult. It's just getting, again, the nomenclature of the follicle versus the oocyte straight in your brain. Okay? Easy enough? Sort of? All right. And we're almost done. I can feel it. I can feel we have come to the end of the day. So, secondary oocyte expelled into the pelvic cavity. All right. So the zona pellucida is covering in the the corona radiata. So ultimately, that's what goes into the pelvic cavity. It is swept into the fallopian tubes by those fimbriae, which we'll discuss tomorrow. Those finger-like projections at the end of the fallopian tubes, where they do the wave-like projection, sort of a peristaltic sort of wave, and they bring the egg into them. All right. If the sperm is present, then we get fertilization. Okay. After fertilization, we do have a second polar body. We'll talk about that later, but don't worry about it. And then what the ovum is fertilized with, the sperm becomes the zygote. All right. If there are no sperm present, then the cell basically degenerates. The excess vaginal tissue and uterine tissue sloughs off. That is known as a period, right? And that is what we're going to discuss on the last class. All right. And just so you have this was a fun. Terry used to love this, middle schmerz. But why are these useful? That's right. Yeah. So if you have, the rhythm or the thermal method, right? So like if you understand the patient can recognize the signs of when she is ovulating, that is of course the optimum time to try to fertilize that egg. So that patient, you can increase your chances of fertility if you can recognize the signs. So you being able to communicate these to your patient again is good counseling if the patient is trying to achieve fertility. Okay? So if you look at this is a good roll up, just like that one from the. This is it, you guys. This is a good one. This is the egg development. Okay. This is the follicle development. And they follow similar paths. So again, if you see this tertiary follicle, does that make more sense what I'm talking about now? You get sort of that antrum that comes sort of all the way around. You just have this tiny little isthmus of cells here. Right? That's the tertiary follicle technically. And then as you get to ovulation, now the Graafian follicle, this middle section that's surrounded by all this fluid, is what comes out for ovulation and ultimately gets into the fallopian tubes. So again, I just wanted to highlight that. So if you guys are astute, you're going to see that tertiary follicle. Like, you didn't talk about it. I know I didn't. That's what it is. Just leave it at that. Okay. Any questions for today? That's all I got. All right. I'll see you guys tomorrow.